All right, everybody can see the screen for the male reproductive system?
Yes.
Okay. All right, so let's just talk about some of the parts for the male reproductive system. Okay. Um, the epididymis, which is going to be the site where the sperm is going to mature. So that's why I call it P. Diddy's house, right? You can remember that. Sperm get matured there. The vas deferens, that's carrying the sperm from the epididymis out to that urethra. Your seminal vesicles, those are going to secrete fluid there, seminal fluid, and that gives energy, fructose mostly, to that sperm so that it can function. Your prostate gland, this is the one they might really ask you about, okay? This is going to secrete alkaline fluid into the semen that helps neutralize the acid, and it helps with the sperm so that it can be motile or swim. And then your Cowper's glands, these I call the cowboy glands. They're only in men. And these secrete fluid that helps with lubrication, protects the sperm from acidity, and it also secretes an alkaline fluid to neutralize urine. And then the urethra, that is going to bring the semen up and eject it, or it will carry urine out to the body. All right, so some hormones that you would need to know. Follicle stimulating hormone in men, that is going to promote spermatogenesis. Okay, I call it the fish. The fish helps with development of the sperm because genesis means new development. Okay, if you know that, then you have new development of sperm. Later, when we talk about cancer, you'll see angiogenesis. So that's new development of blood vessels. So that genesis, knowing your words, will help you. All right. And then the production of sperm is going to happen with this from the sperm cells. So spermatogenesis, production of sperm. Luteinizing hormone, I call this the little hoe. This is going to stimulate testosterone production in the boys. Okay. And you know their nose is wide open whenever that little hoe comes around, or that luteinizing hormone. All right. So that's going to help with testosterone. And testosterone is needed to mature the sperm so it's ready for reproduction. It's going to help with those sexual characteristics like groin hair, underarm hair, protein metabolism, and muscle development. And then for the female, we have the vulva with your mons pubis and your labia majora minor, your clitoris, which is similar to the penis, it's erectile tissue, the vagina, which is this muscular canal that holds everything up in there with the cervix, the Bartholin glands and the Skene glands only in females, and these are for lubrication, both of them. The uterus, this is where the ovum can be implanted. And that's also what's going to shed when someone has a period, that uterine lining, that endometrial lining. The cervix, that opens up into the uterus and the neck of the uterus. And then you have the external OS, which opens from the vagina. There's mucus there. That prevents the vaginal flora from going up into the uterus. The internal OS, your fallopian tubes, these are bringing the ovaries out to the uterus. The ovaries are producing estrogen, progesterone, and ova. And then your breasts, which are adipose tissue, and those are going to help produce colostrum and milk for the newborn. Again, on the right, it's just a little breakdown. Maybe it'll make you understand it a little bit better, a little bit simpler. So, you just want to know what these parts are and basically how do they work. So, when we look at the cycle, okay, your book says 21 to 45 days. Most people, it's going to be 28 days. During that menstrual cycle, if during that process, if the egg doesn't get implanted, that menstrual cycle is going to occur. And so, that's the shedding of that uterine lining. So if you look at the right, it talks about the menstrual cycle. If no conception or implantation occurs, then the body's going to naturally flush the system out. That's how it cleans the system. This is why you don't need to douche. The corpus luteum will degenerate. The progesterone and the estrogen levels are going to drop here, and the endometrium is going to slough off and flow out of the uterus. And that's actually what a period or a menstrual cycle is. Okay. Estrogen secretions help rebuild the endometrium, it refurnishes it. And then that all supports conception and implantation. So progesterone is going to help with the implantation. If no fertilization occurs, estrogen and progesterone levels will drop, the corpus luteum and the endometrium will degenerate. And again, that's going to be that menstrual cycle. Any questions on any of that? So for women, okay, the follicle stimulating hormone is going to help mature the ovarian follicle. So it's going to help that egg become mature, okay, by secreting estrogen or causing proliferation or thickening of the functional layer of the endometrium. So by causing that thickening, if we're going to put an egg there, it's going to help that egg grow. As those luteinizing hormone levels increase, ovulation would take place with the release of a mature ovum there. And then the luteinizing hormone would convert that ovarian follicle into the corpus luteum. And that is going to cause an increase in the production of progesterone there. That progesterone gets that area ready to put that egg in there. If there's no fertilization, then the estrogen progesterone levels drop. The corpus luteum, the endometrium degenerate, and menstruation starts. Okay, after menstruation occurs, then the ovaries will release those hormones that tell the uterus to grow a new lining and prepare a new egg. As the uterus prepares the new lining, one of the ovaries release an egg. This is called ovulation. Ovulation occurs about halfway through the cycle. So remember, I keep telling you Valentine's Day. The reason why I say Valentine's Day is because most cycles are about 28 days. So Valentine's Day is when we're going to get whoopee, hopefully. So that reminds you that halfway through that cycle, about 14 days in, that's the best time to make a baby. All right, that ovulation is going to occur. It's going to travel through the fallopian tube, that egg. If it gets fertilized, then somebody's going to get pregnant. If it doesn't, then everything's going to break down and shed away. These hormones that we're talking about come from the pituitary gland, okay, and they regulate the reproductive system. So the main ones are follicle stimulating hormone, luteinizing hormone, and they're signaling either the ovaries in the female or the testes in the men to start the processes needed. So it affects the function of the ovaries and the testicles. For the ovary to grow, it's going to help it with ovulation, the follicle stimulating hormone. And for the sperm to be produced, it's going to help the male produce sperm. So just remember, the fish is going to produce either an egg or sperm. Your sex organs produce either steroids or hormones. So progesterone, testosterone, and they do this in response to the luteinizing hormone. So you know the little hoe luteinizing hormone for men is going to be that testosterone. For women, it's going to cause ovulation, the release of that egg. Okay. Some disorders that we can have that might affect the penis or the scrotum. So you can have strictures there, like scar tissue. Sometimes when we talk about Peyronie's disease, this is the problem with that because it causes the penis to curve or to develop adhesions in there. And that can come from things like sexual activity, sports. Other strictures could be in there for different reasons, okay? But these strictures can block the release of the urine. Sometimes with prostate issues, it's going to block the release of the urine. Urethritis, this is usually from a sexually transmitted disease. So remember, we have gonococcal, non gonococcal. So gonococcal is from gonorrhea, non gonococcal is usually from chlamydia trachomatis. Both will lead to things like burning on urination and discharge. Phimosis. This is where we have a problem with the foreskin, okay? And we need to pull it back a little bit. And then paraphimosis is where the foreskin is retracted, but it's too tight. And that can cause edema. It can cut off circulation. Hydrocele, I put that one over there. I'd probably know hydrocele and urethritis, I would know, and torsion of those testes. Those are the big ones that I would expect them to ask you about. Hydrocele is going to be where we have fluid accumulating, okay? And it accumulates around that tunica vaginalis. So if you look at the picture on the right here, look at the tunica vaginalis specifically. Okay, look how skinny it is on the left versus the right. So on the right, it's thick and it's full because it's full of fluid. And that fluid is going to cause compression and problems. It's usually worse during the daytime, reabsorbs more at night. It can happen in babies. That's a congenital type, okay, of defect. And it can also happen in the older male, which is probably where you guys typically see it in the nursing home. Okay. You'll see some of your older gentlemen, it'll be extremely edematous, okay, from the fluid. And then torsion of the testes. Remember, the testes are suspended on that cord, that spermatic cord. They can become twisted. Okay. And when they twist, it causes an interruption in the blood supply to the testicles. It has to be corrected. If it not, they're going to lose their testicles because it's cutting off the circulation there, the blood supply. It's a medical emergency. All right. So one of the ones you really need to know is the cryptorchidism. This is where the testicles do not descend. Okay. And it's called male descendant, meaning abnormal descension. All right. And we don't know why. Sometimes they could also have ectopic testes where the testes are actually outside of the scrotum. But the one they ask more about is the testicular. You need to know that this occurs mostly in men between the ages of 15 and 35. They'll need to go to the sperm bank and give up sperm because high risk of infertility here because this is affecting the area where the sperm is produced. One side of the scrotum typically is going to feel heavier than the other. Um, Testicular exams can help detect this. If we don't do treatment by the age of 5, it severely increases the risk for the testicular cancer. Typically, we would want to repair this by the age of 2. And usually it's going to have like a heavy filling in the scrotum. Torsion of the testes. I talked about this a minute ago. So this is twisting of the testes or the spermatic cord, compressing those blood vessels. It's going to cause ischemia. It can happen spontaneously or after trauma. Peyronie's. This is where we have scar tissue on the penis that causes a significant bend or pain. It can lead to erectile dysfunction. It's believed that it's from repeated injury from either sexual intercourse or athletic activities. And there may be some hereditary component here with connective tissue disorders. So that could be like SLE or something along that line that could lead to problems here as well. Prostatitis. Key terms here for this are going to be that tender, swollen, and boggy gland on palpation. The secretions themselves will have urine and bacteria in them. If it's a bacterial type, it can spread up the urethra. It's called ascending because it's going up the urethra. Primary cause is E. coli, and it can occur with things like UTIs, BPH because of that stricture, the blockage, that static urine, STDs like gonorrhea, catheterization, or sometimes infections that are in the blood. E. coli can be in the blood too, certain types of E. coli. All right, so what would we see here? We'll see inflammation of the prostate. And again, if it's bacterial, it's going to be swollen and boggy when we palpate it. Some of the other symptoms would be dysuria, so painful urination, frequency, urgency. Other parts of the reproductive tract could be affected, like the epididymis or the testes. Just to recap on some of your STDs, okay? So gonorrhea, this can cause urethritis, painful urination, and purulent drainage. Syphilis, this is caused by Treponema pallidum. The gonorrhea is Neisseria gonorrhea, sorry. For syphilis, contact here with the skin, any kind of cutaneous lesion during intercourse, and syphilis is systemic. Usually that's going to end up in your body. Okay, it can go dormant once you have the first active infection. Chlamydia, this also causes urethritis. Remember, we have gonococcal, non-gonococcal. So gonorrhea is the gonococcal. Chlamydia trachomatis is the non-gonococcal. This can also infect newborns as well as gonorrhea and syphilis. Genital herpes, and then genital warts, which is the condylomata acuminata. We can also have epididymitis and orchitis. So this can be inflammation of the epididymis, the coiled tube at the back of the testicle. The orchitis is infection of the testicle itself. It could be a combination of both. This can be from bacteria or viral infections. So the mumps, you see there, the mumps can cause a lot of problems with the testicles. Before puberty, it's usually caused by E. coli, and in sexually active men, STDs like gonorrhea or chlamydia. And then you have some pictures there. Okay, so you can see which one would be epididymis versus orchitis. So orchitis is going to be the actual testicle, whereas if you look on the left, the epididymitis is that coiled tube at the back of the testicle. And it can happen in combination where both are affected. Balanitis. This is a fungal infection of the glans penis. We usually see this in uncircumcised males. During sexual activity, this can be transmitted. It's a fungus, Candida albicans. It usually first appears as penile vesicles that later develop into patches that cause severe burning and itching. So you can see the white area there on the penis, and you can also see how red, okay, that it is, how irritated that it is. So here you have infection of the penis and that foreskin around it. BPH, benign prostatic hyperplasia. Okay, this is hyperplasia of the prostatic tissue, and it occurs around that urethra. It compresses the urethra. It can lead to obstruction. The hyperplasia seems to be some imbalance between estrogen and testosterone. We'll see this in older men, usually over the age of 65. I would know that. There's no connection between BPH and cancer. Rectal exams will show an enlarged gland. Usually, when we do a rectal digital exam, we can feel it. It'll usually be similar to the size of like a walnut. Incomplete emptying of the bladder can cause obstruction and infections. Continued obstruction will cause bladder distension, dilation of the ureters, hydronephrosis, where the urine is now backing up, and then compression and possible kidney damage, because if that urine backs up, it's heavy, it's going to put pressure on the blood vessels there. It's going to cause constriction. They're not going to get flow, and that will eventually lead to kidney failure. Initial signs for BPH are going to be obstruction of the urinary flow, hesitancy, dribbling, decreased flow of the urinary stream, and all these cause a narrowed urethra. Incomplete emptying of that bladder is going to lead to frequency, nocturia, and frequent urinary tract infections. So this is a challenge. Your book says 65 and older, so follow that number. Okay. I just tried to give you a little picture here to see what's happening so that you can get a better glimpse of it. But follow the symptoms and signs on the previous page, okay? Cancer of the prostate, most is going to be in men over 50. It's invasive to the lymph nodes, the urethra, and metastatic to the bone. This is a big one, the bone for this one. Tumors will vary in how differentiated they are. So remember, when cells are undifferentiated, they're going to be more aggressive. Okay. More aggressive means it's going to spread. And usually they call this anaplasia. The cells don't look alike, and they don't play. Okay. When the cells don't look alike and they're undifferentiated, they're aggressive. So this is going to spread rapidly. Most are adenocarcinomas that arise near the surface of the gland, and it's detected by a hard nodule at the back of the gland or the periphery. It usually is detected on a digital rectal exam. As the tumor grows, we'll see obstruction, signs of hesitancy, a decrease in the stream and the frequency, and bladder infections known as cystitis. Typically, we monitor it with PSA levels, and a biopsy is the only way to confirm any kind of cancer. Bone scans will help us look at how much it's spread. So that's what a bone scan does. It'll light up the body and show us where the cancer went to, how bad it is. Most testicular tumors are malignant for testicular cancer. This condition occurs primarily in the 15 to 35-year-old age group. Some of the malignant tumors will secrete things like HCG or alpha fetoprotein, so we can use those markers to monitor the growth or the spread. These tumors, testicular ones, will usually spread from the iliac first into the para-aortic lymph nodes. Once it gets into lymph nodes, remember it can go all through that lymph system. And then I want you to think about this. Where do the lymph nodes dump at? Who remembers this? Where are they dumping at? Somebody knows. Don't be afraid. Be afraid on the test, not now. Where are they
Into
dumping
the
at those? Go ahead.
into the blood system.
That's right into the inferior vena cava. So now it has the potential to spread through the veins and the lymph nodes. So you have to think about that anytime something gets into the lymph nodes. Okay. So metastasis will spread now through the blood to the lungs, the liver, the bone, the brain. Testicular cancer is the most common solid young tumor in men, probably a test question. For this reason, monthly testicular exams check for an unusual hard mass. It has a hereditary pattern. It has a predisposing factor of cryptorchidism. The tumors are hard, painless, unilateral. Testes may feel enlarged or heavy. And they can have other complications. So hydrocele, if the tumor secretes, and this could be true for any tumor, okay? Any tumor that secretes hormones can put men at risk for gynecomastia. So this means they have breasts that look like a teenage girl, okay? They look like they're budding, and sometimes they'll secrete a milky substance. Menstrual disorders, okay? Amenorrhea is absence of menstruation. Remember, it's primary if they've never had one, usually by the age of 16. Secondary if they've had a period, but it stopped because maybe they become anorexic or some other hormone imbalance. Dysmenorrhea is painful menstruation, and usually this is caused from too much prostaglandin. Abnormal menstrual bleeding is a common concern. So you have different types. Menorrhagia, which is prolonged duration of flow and an increase in the amount. Menorrhagia, bleeding in between those cycles. Polymenorrhea, where you have lots of cycles, they're very short. And oligomenorrhea, where you have a long time in between cycles. So when you think about that one, think about that's the best one, right? The longer, the better. I'd be happy if they just stopped altogether, is what women say. I don't have to worry about that anymore, but that's what most women say, right? I'd be happy if it just stopped altogether. I'm sure you guys would be happy too. Endometriosis. This is where we have endometrial tissue growing everywhere, okay, inside that reproductive system. So it's growing on the fallopian tubes, the ovaries, the rectum. Where should it be growing? Even the small intestines can be affected here. It should only be growing in the endometrium, but it's growing everywhere else. The problem is this tissue don't know that it's outside of the uterus. Okay? It doesn't know that. So whenever you get your period, it's going to bleed from everywhere. All right? And so this is what causes the severe pain, the inflammation, because now you have bleeding outside of the endometrium and the uterus. So it's going to cause pain because the blood has nowhere to go. It has no way to get out. This can happen with every cycle. And because you have blood in there, it irritates and damages the tissue in there. That can cause development of fibroids. The fibrous tissue itself can cover the fallopian tubes and block the egg from coming through. Primary signs and symptoms of this are painful menstruation or dysmenorrhea. It can become more severe every month, but other symptoms of this are painful intercourse, dyspareunia. Pelvic inflammatory disease. This is infection of the upper female reproductive tract. Okay, you want to remember it's the entire reproductive tract here that is affected. So the uterus, fallopian tubes, and or the ovaries. It could be acute or chronic, and it usually starts in the lower reproductive tract and spreads upward. So it's called ascending. It can be caused from bacteremia. STDs is a common cause of this, okay? Sexually transmitted, especially chlamydia and gonorrhea. Non-sterile abortions or child abuse. Now, you might not see too many non-sterile abortions here in New Jersey because we still have clinics. But what about in Texas where it's now illegal? And more states are going to become illegal. They're trying to make New Jersey an illegal abortion state right now. So as these states become illegal, you are going to have to watch people for this because people are going to do what they need to do with those babies. If they don't want them, they're going to get rid of them. However means they need to do that. Closing the abortion clinics isn't going to stop that. It's just going to make it more unsafe. It's just going to make it more life threatening. It's just going to make it more of a problem. All right. So infection in the reproductive tract can come from an infection like appendicitis, where they end up with an infection in the peritoneal cavity, and then it spreads up to the reproductive cavity. So that's another way that they could get this. They could also get peritonitis if they had pelvic inflammatory disease, because that could also spread into the peritoneal area. Fibrocystic breast changes. So these are changes that happen usually during the menstrual cycle, and it's from fluctuating levels of estrogen most of the time. It causes connective tissue in the breast to be replaced by fibrous tissue. Fibrous tissue doesn't work. Increased fluid that's in the breast during the secretion phase of the menstrual cycle can build up in cysts that are surrounded by that fibrous tissue, and it is unable to escape at that point. This causes the cyst to become enlarged, and it'll degenerate the normal tissue in the breast. So usually these people will be more painful towards the end of the menstrual cycle, where the breast pain is going to be really increased towards the end of that menstrual cycle. Breast cancer. Most of this we see in women between ages 50 and 69. These tumors are usually on one side or unilateral. If they get it early, it's usually more associated with aggressive growth. Different types can come from different epithelial cells. If it gets into the lymph nodes, which I told you the most common place this happens is in the upper outer quadrant, which we call the telespence, that goes up in there, and it can easily spread there to the axillary lymph nodes. And if it's in the lymph nodes, then what? Where are those lymph nodes dumping at? Where are they dumping at?
In the blood, in the vena cava.
In the vena cava. So now we got risk for spread, okay? And we can have widespread metastasis to the lungs, the brain, the bone, and the liver. Predisposing factors, first degree relative with the disease, genetics, BRCA1 or BRCA2. So if you get those genes from your parents, BRCA1, BRCA2. Longer or higher exposure to estrogen. Not having a baby or having a late first baby. Lack of exercise, smoking, high fat diet. High fat diet never leads to anything good. The only thing good there is the food. Radiation therapy, cancer of the uterus, the ovaries, or the pancreas. Now, the uterus and the ovaries could be pretty devastating, as well as the pancreas. Remember, ovarian cancer, cancer, that's a deadly one. Pancreas, if it happens in certain parts of the pancreas, you're going to die quick. If it happens in the neck, you might be able to get something called a Whipple procedure. Lymph node involvement. Then we go into secondary tumors because of the lymph node. Again, if lymph node is involved, it can end up being in the blood as well. Usually signs are going to be a single, small, hard, painless nodule. The nodule might be movable in the early stages, but later it won't move. It'll become fixed. Other signs, dimpling of the breast, retraction or discharge from the nipple, changes in the way the breast looks. Biopsy can confirm the diagnosis. So this is just showing you, and this will be in your slides, okay, how it spreads. And if you notice, they show you both the vein and the lymph nodes because it can spread either way. Cervical cancer, most cases HPV or herpes simplex 2, which is STD. There are vaccines for the HPV. Routine pap smears recommended. The majority of cervical carcinomas come from squamous cells, and biopsy confirms all cancers. So some of your risk factors over there, okay? HPV and herpes simplex are going to be the main ones. But then early sexual relations, long-term contraceptives, smoking. It's going to be asymptomatic, the cervical cancer in the beginning, detected by the pap test. If it becomes invasive, we'll typically see slight bleeding, spotting, slight watery discharge. Anemia or weight loss can also accompany the signs. Endometrial carcinomas, this is cancer of the uterus. This is common in women older than 40, but the majority will be 55 or older. These clients have a history of increased estrogen levels. Also, we'll see higher levels of uterine cancer in women that are overweight or obese. Classic signs: painless vaginal bleeding or spotting. And this is because of erosion of the tissue. Pap smear, not dependable. We have to aspirate cells from the uterus and do a biopsy to confirm. Late signs: a palpable mass, discomfort or pressure in the low abdomen, and bleeding after intercourse. Tumors have a poor prognosis, and a lot of times they've already metastasized to the lungs by the time we diagnose. They grow slow, but they're invasive. Ovarian cancer, which I call ovarian cancer, this is considered a silent tumor. Very few of them are diagnosed in the early stages. Usually by the time they're diagnosed, prognosis is poor. These are aggressive cancers. They can spread through seeding, where it plants along the membranes, usually in the body cavities, and it spreads. Early indications are bloating and fullness, indigestion, and frequent urination, as well as backache and pain with intercourse. A large mass can be detected through pelvic exam, but that's usually not going to be early on. That's going to be a little bit later. One of the things that helps it spread is the way it's able to disperse itself throughout the peritoneal cavity using that seeding process. Remember, aggressive are going to be are going to have anaplasia where the cells don't look anything alike. All right, chlamydia. This is an STI we want to consider caused by chlamydia trachomatis with males. They'll end up with urethritis and epididymitis with this. So they'll have painful urination, itching, white discharge from the penis, painful swollen scrotum, usually unilateral, fever with the epididymitis, and swollen lymph nodes. With females, a lot of times they'll be asymptomatic, and this can lead to pelvic inflammatory disease or infertility, and it can affect the newborn. Viral infections, genital herpes caused by herpes simplex. This can be caused by herpes simplex 2 or 1. Herpes simplex 1 is possible with oral sex. Lesions are similar there in genital herpes or herpes 2 to HSV 1. They'll have outbreaks of blister-like vesicles on the genitalia. Usually before the outbreak, they'll have tingling or itching. The lesions are very painful. And then after the acute stage, the virus will go back into the dorsal root ganglion. These clients are going to be more infective when symptoms are present, but they can still spread when symptoms are not present because it remains in the saliva and the body fluids. Condylomata acuminata, these are genital warts caused by HPV. The incubation period for these can be about 6 months. These people can be asymptomatic. The warts can vary in how they look. They usually have a cauliflower type look, though. They can be removed through different methods, but this can predispose the female or male to, well, really the female to cervical or vulvar cancer, not the male. Okay. Protozoa infections. These are like trichomoniasis. This is caused by Trichomonas vaginalis. This is a protozoa infection. Men are usually asymptomatic. Women can be subclinical. This will flare up when she has an imbalance in the microbial content there. And so we have intense itching. Systemic treatment is needed for both partners here because otherwise they'll spread it back and forth. All right, any questions about any of that we just went over for reproduction, sexually transmitted diseases, any sort of problems that we might see? Any questions on any of that? All right, let's move on then. And now we're going to talk a little bit about genetics. Okay. So with genetics, we're talking about different terminology here. Differentiation is how the cell carries out its function. So when it's well differentiated, we know that it's able to do its job. When it's not, usually it's not in control. The body's not able to control it. And it's either growing out of control or it's not communicating. It's not doing the things that a cell that is specialized for that cell should be doing. Mitosis is when we produce two genetically identical daughter cells. This can come from a single parent cell. This form of cell division functions in growth, tissue repair, and asexual reproduction. It's part of the cell cycle, and it requires genetic control, DNA, RNA. When there's a mutation, usually there's a change in the genetic makeup or the DNA of the cell. This could be inherited or it could be spontaneous. If a DNA in a parent cell is altered and passed on, then the offspring will carry the mutation. And apoptosis is that programmed cell death. It's controlled by certain genetic elements in the body. Most of your blood cells are going to have cell death after about 120 days. That's your red blood cells. In sickle cell, it's only about 10 to 20 days because they're damaged. Neoplasm or a tumor. This is growth of the cell that is not responding to the genetic controls in the body. So the cell's just doing what it wants to do. It's a rebel. And it's going to reproduce even though the body doesn't need it. It's going to deprive other cells of food. And it's going to consist of atypical or immature cells. The characteristics of the cells themselves will depend on where the tumor arose from. They all have a unique structure and growth pattern. So benign is a non-cancer cell. It usually only grows locally. It cannot spread or invade through metastasis. Malignant cells invade the neighboring tissues. They enter the blood vessels and they metastasize and destroy the tissue adjacent to them and other places as well. So, characteristics of a cancer cell, for one, it's going to increase in the number of cells. It's going to get a lot, a bunch, way more than we need. The cells won't have the normal arrangement, and that's going to affect their ability to function. The size and the shape can vary from the normal size and shape. So that's what we're talking about when we talk about undifferentiated cells. They don't look the same size or shape as the normal cells. They divide in an uncoordinated manner, so they're not responding to genetic controls in the body, and they're not being even controlled by the body because they're out of control. And they lead to destruction of things around them, like the neighboring tissue. Some rules for when we talk about the origin or whether it's benign or malignant. Okay, so for fatty tissue, the root is lip and the benign is oma. So lipoma or lipoma is a tumor of fatty tissue. Gland tissue is known as adena. So if we have malignant tissue, that is carcinoma. So we have adenocarcinoma, that is malignant tumor of the lining of a gland. Or fibrous tissue, the fibrous tissue is known as fibro. For malignant connective tissue, we use the term sarcoma. So for malignant or fibrous tissue, it would be fibrosarcoma. You should know the differences between benign tumors and malignant tumors. So, one, benign tumors are going to be more differentiated. They're going to look more like the normal cell, and they're going to act more like the normal cell. So, why they may grow faster because they're making that little tumor still, okay? The mitosis process is going to be close to normal mitosis. The cell size and shape is going to be close to normal, and the cells will look similar to one another. With malignant tumors, the cells are not going to look like one another. They're undifferentiated. They have different sizes, different shape, large nuclei. The mitosis is typically increased, so it's happening very quickly, that reproduction, and it's atypical. It's not following a pattern we would expect. With benign cells, they'll grow faster, but not as fast as these malignant ones. So compared to malignant tumor, it's going to grow slower. And what we'll have is an expanding mass. And usually they'll have a capsule around them. That's what encapsulated means. So it has this capsule around it, which is important when we talk about benign versus malignant, because malignants don't have a capsule around them. The cells aren't tightly bound together, they're loosely together. And so they can easily break off. They'll grow quick. So they're not adhesive. That means they can easily break off and infiltrate other tissue. For benign tumor, it's going to stay in that local area. For a malignant tumor, it's going to invade anywhere it can or metastasize through the blood and the lymph. So if it gets in the lymph nodes, it's going to go in that lymph system, and that's how it can end up in the blood, because that lymph system is dumping in that inferior vena cava. As far as life-threatening effects, so for a benign tumor, only usually if it's in the brain, because in the brain, it's going to cause dysfunction there with compression to the flow in the brain, and it's going to disrupt all that since there's no place for anything to go. If it starts to do compression there, it can cause severe damage. Same thing with malignant. So usually malignant will destroy tissue and spread the tumor in the brain, and that will be the cause of the death. Some other systemic effects that we'll see with malignancies are weight loss and cachexia. Cachexia is different from just weight loss. That's where we have actual muscle or tissue wasting. And the body is starting to break down because it doesn't have enough nutrients. These clients can develop anorexia, fatigue, pain, and stress. And we'll see increased demands on the body from the tumor cells, because those are going to continue to grow, and they're going to contribute to the weight loss and the cachexia by stealing some of those nutrients that should be designated to the normal cells. The anemia caused by blood loss at a tumor site. So this can be from the tumor and the invasion of the tissue, ulceration of those blood vessels. Nutritional deficits can reduce the amount of hemoglobin being produced. Severe fatigue caused by inflammatory changes, cachexia, and anemia can occur here. And then clients will also have difficulty with other things, like the treatment schedule can be very tiring. And there's going to be some psychological, because they have to deal with the fact that they could be potentially dying. They may need some sort of surgery because their body structures have to be removed because they're cancerous. So maybe a breast removal or a testicle removal, and they're going to have to deal with that. And again, just like a woman is going to feel some sort of way when her breast is removed, so is a young man. If he's, 15 or 20 years old, he's going to have a problem with his testicle being removed or being replaced with prosthetics. Other things that we could see is inflammation and fluid buildup in the body cavity, or effusions here, infections because the host resistance will decline and they're not able to fight as well. Bleeding because of the erosion of those blood vessels, and then paraneoplastic syndrome they like to ask about. So this can happen with certain cancers where they can develop like Cushing's syndrome because the body is releasing too much cortisol. Tumor cells release different substances, and those substances can cause the neurological function to be impaired there. Another thing they can develop from small lung cell cancer is syndrome of inappropriate antidiuretic hormone, where they're producing too much diuretic hormone, and so the body's retaining fluid. So those are just some of the things that can occur from that paraneoplastic. So we'll look at some tumor markers, enzymes, hormones, antigens, and we'll try to see where the cancer is coming from, what type of cancer that it is. That's going to help us determine the prognosis and some sort of course of action. We'll also look for CEA, carcinoembryonic antigen. This is for things like colon cancer, HCG, human chorionic gonadotropin for testicular cancer, alpha fetoprotein for liver or hepatocellular cancer, CA125 for ovarian cancer, and then PSA for the prostate cancer. We also use things to screen high-risk people, genomic tumor assessment. This can help us identify any potential genetic mutations that are independent of hereditary, but only occur with the disease process itself. So with the spread of malignant tumors, we have invasion. The tumor cells can grow into the adjacent tissue. This can happen with uterine cancer, where it will invade the vagina. We have metastasis. This is where the cancer is spread to different sites through the blood or the lymph or other body fluids. Example is where you have cancer of the colon and it spreads to the liver. So those abnormal cells like to travel. All right. If you're a traveler, consider becoming a metastatic cancer cell. So you can go wherever you want in the body if you're a metastatic cancer cell. And that's really what it's talking about there, just to help you remember that you can travel to any of the organs, the tissues, and you're doing this through the blood or the lymphatic system. Remember, ovarian cancer, me, that uses that seeding process. So you have the primary ovarian tumor. It spreads along that peritoneal membrane and it spreads that tumor and produces secondary tumors, or it spreads that cancer and produces secondary tumors in other places of the body. Breast cancer, remember that we use cytology to screen anybody high risk, to confirm a diagnosis, or to monitor the course of the cancer. We'll use biopsies to confirm any malignancy. That's the only dependable confirmation. For staging the tumor, stage 1 is usually going to be no lymph node, no metastasis. Tumor less than 2 centimeters. Stage 2, 1 lymph node, no metastasis. Tumor can be up to 5 centimeters. Stage 3, up to 2 lymph nodes. Tumor can be fixed, greater than 5 centimeters, no metastasis. And then stage 4, tumor any size, fixed to the chest or the skin, 3 or more lymph node involved, and metastasis. Carcinogenesis, this is where the normal cells are transformed into cancer cells. And this can vary with respect to time. Cancer is considered multifactorial because it can be caused by different things: environmental factors, changes in the expression of the gene, infection, or viruses. Some cancers have well-established risk factors. Carcinogenesis is the actual process of tumor development, and evidence supports that there is a multi-step process here. Okay. The cell eventually can no longer control its own growth or location, and it travels to different areas. So if you look at the screen here in carcinogenesis, okay, where the gene gets affected in some way, all right, and now because of that, it's going to produce these cancer cells or these different cells, and they will grow and travel through the body, all right? And here's the process on the next page of how that's going to happen. So exposure to any of these issues, environmental, genetic, and then we have the initiation phase. So the cells start to mutate, okay, because they either inherited the mutation or it could happen during that DNA replication after exposure to a cancer-causing agent. Promotion occurs with additional changes to the cell, So this is when we have additional genetic damage and cancer starts to develop. So prevention activities are focused on this stage to reduce the promotion or the promoting factors of the cancer. So this is when we're talking to people, trying to get them to stop smoking, trying to get them to change their diet, not eating those high fatty foods, not drinking too much, trying to reduce their stress. And then progression, where the cells are going to increasingly become undifferentiated. Okay. So they change in the way that they appear and they behave. And that happens anytime it metastasizes. So your initiating factors or your procarcinogens, these cause the first irreversible change. I would know this. They don't create a tumor, though. They just cause the first irreversible change. Okay. And then you have exposure to those promoters like hormones, environmental chemicals, and those are going to cause more changes in the DNA. Now we see less differentiation and we see an increased rate of mitosis, or the cells aren't going through the death cycle or the apoptosis. So here we have abnormal cells or dysplasia or anaplasia. Remember, Annie don't play. Annie is going to be those aggressive malignant cells. And this leads to tumor development. So with one, the initiation, we have the irreversible mutation of the DNA. Then two, we have repeated exposure to the carcinogens. That causes us to be at an additional risk. And then we have those changes because of that continued exposure. We have additional changes to the DNA and the cell structure, and eventually this can lead to cancer. Prognosis. So when someone is cancer free for at least 5 years without recurrence, it's considered survival, or it's considered cancer free. Some cancers, like childhood leukemias, can be considered cured after a 10-year cancer-free period. Remission is when they have no clinical signs of the cancer. And then we look at the life expectancy and the death rates for specific cancers, and we know that the highest rates for fatal cancers in men and women are going to be men, prostate, women, breast. Okay. And then both men and women, lung cancer and colon cancer. All right. Skin cancer. This is usually easily diagnosed and treated. It usually has a good prognosis unless it's malignant melanoma. Malignant melanoma will have a more of a poor process. Ovarian cancer. Remember, I call that "oh, bury me" cancer because look at it. Poor prognosis, high mortality rate. And then brain tumors, because both benign and malignant are life-threatening. This can cause compression of that brain tissue, and the primary tumor is usually going to be fatal. Basal cell carcinoma. This is the most common form of skin cancer. We'll usually have that little central ulceration there, like you see there. Characteristics would be lack of pain, itching. The lesion will grow slowly and it's invasive. So again, incidences, prostate and breast as far as most common in men versus women, and then lung for both, colorectal for both. All right, now we're going to start talking about, that was cancer. Now we're going to start talking about heredity. All right, so your gene is your basic unit of heredity. This is how traits are passed on from your parents to you and from you to your kids. And when we talk about genetics, we're looking at how what allows these traits to be inherited. About half of your genes will come from your mom and a little less than half from your dad. And the genes will shape how you look, how your body functions, and how you grow and change over time. All right, so every person gets 2 copies of every gene, one from each parent. They're not always identical. All right. So when we talk about heterogeneous, what we're talking about is you have 2 different genes, right? One, it looks one thing and one is another. When we're talking about homogeneous, okay, and homos means 2 of the same. Homogeneous is going to be 2 of the same genes. Each variation of a gene is considered an allele. For example, if a gene contains information for eye color, one allele might code for blue eyes, another might code for brown eyes. These alleles allow for diversity. There are a couple different types of inheritance patterns. We're going to learn about them. You have autosomal recessive, and this involves a recessive L. So if it's autosomal recessive, you usually need 2 of the same genes in order to get this disease or this trait. And they happen on the non-sex chromosomes, okay? X chromosome is the sex chromosome. Autosomal dominant, this involves a dominant allele on a non-sex chromosome. So a dominant allele is only going to require one of those genes for you to inherit the trait or the disease. Some diseases are called autosomal recessive because the only way you can get them, you have to get 2 bad genes, one from mom and one from dad. An example of that is sickle cell. In sickle cell, it's autosomal recessive. So you'll either get 2 bad genes, one from mom and one from dad, and you'll have the disease, or you could get 1 bad gene from dad, 1 good gene from mom, and you would have the trait. You could also get no bad genes, and you wouldn't have the trait or the disease. So when they ask you what's your risk factor of how you could get this disease, okay, that's what they're talking about. What would be their percentage? So then you think about if dad could give it to me, right? And mom not, then that would give me what percentage of getting it. And we'll talk about that a little bit more when we get closer to that part. Autosomal dominant means that mom or dad can give you 1 bad gene and you're going to have the disease. Huntington's, I believe, is an example of that. In Huntington's, just one of your parents would have to give you that bad gene for you to have that disease. So the way you could get it is dad could give you a bad one and you could get it. Mom could give you a bad one and you could get it. Both parents could give you a good gene and you don't get it. X-linked recessive is when the allele falls on the X chromosome. So we'll see this in some of the diseases out there, okay? It lands on the sex chromosome. And X-linked dominant is a dominant allele on the X chromosome also, which is the sex chromosome. Y-linked would involve a allele that lands on the Y chromosome. So mostly we'll be talking about either sex link or autosomal recessive or autosomal dominant. Now, any offspring will inherit genes from both parents, and different forms of the gene are called alleles. And this can make different things happen. So maybe you end up with a straight hairline, or maybe you end up with early balding. The ultimate combination of the chromosome pair is what makes the different variations possible. And you could end up with a straight hairline depending on what genes you get, whereas your sibling could end up with the balding characteristics that are inherited from either your parents or your grandparents. When we talk about cells reproducing, mitosis is the type of cell division that occurs with non-reproductive cells, and it produces exact copies of the parent cell. Meiosis is cell division that occurs in the reproductive cells, the gametes. This produces the egg, the sperm, and half of your genetic material. There are 23 chromosomes in every gamete. The gamete is just the egg that is produced there, okay? And it's part of it actually, because together you're going to have a gamete from the female and a gamete from the male. They're going to meet together, and when they meet, they'll end up with 46 chromosomes, 23 from mom, 23 from dad. All right, so every human ends up with 23 pairs. 22 are considered autosome. That means they're not on the sex chromosome. And one pair of sex chromosomes, either XX or XY, depending on if you're male or female. A karyotype, this is just a representation of the chromosomes, and they're arranged in order of size. We can use this if someone has a chromosome disorder to see that disorder by the arrangement or the pairs. Of the 23 pairs of chromosomes in every human cell, 22 are not involved in controlling gender. Those are called autosomes. You can have congenital defects where there's damage to the baby. These are present at birth. You can have genetic abnormalities from the genes. Malformation, where something doesn't form right in the body. Chromosome abnormalities, and genes, which are segments of the DNA that code for a specific trait. And DNA is what makes up your chromosomes. So if a baby were born with a congenital anomaly, that's usually going to affect the structural, functional part of the body that's present at birth. A congenital malformation is usually only structural defects themselves. Now, let's look at this karyotype, okay? Again, humans have 23 pairs that will join together, okay, to form the zygote. So 23 pairs from mom, 23 pairs from dad. When they get together, they form that zygote, which will have 46 pairs. The karyotypes will show all pairs. 1 through 22 are autosomes, and the 23rd pair is chromosomes. We don't expect those to look alike. So if you look down in the right-hand corner, you'll see X and Y there. The 23rd pair is the sex chromosomes. Males have XY, females have XX. A male child gets the X chromosome from mom and Y chromosome from dad. Female gets X chromosomes from both parents. During meiosis, the sperm and the ovum will receive 23 chromosomes, one chromosome from each parent. When that egg is fertilized by the sperm, the resulting zygote will have 46 chromosomes or 23 pairs. This is an assortment of genetic information from the parents. So you're getting a little bit from mom, a little bit from dad. And these combinations are so many of them, okay? There's so many different combinations here that usually only identical twins will have the same genes and the same DNA sequence. So DNA is considered a unique identifier, and this is why they can use it to determine if someone was somewhere or not when they're doing a criminal investigation. Genes control all physical characteristics like your eye color, color blindness, and metabolic processes that occur in the body. Sex chromosomes are the X and Y chromosomes, and they decide whether you're male or female. They also decide what our sexual characteristics will be. Women are going to have 2 X's, men X and Y. This means that the sex of the child is determined by the father. All right, males have one X and one Y chromosome, which means that the male gamete can have either an X or a Y chromosome. Chromosome disorders can be diagnosed by identifying abnormalities on a karyotype. Failure of chromosomes to separate during meiosis or non-disjunction can result in monosomy or trisomy. So what does that mean is they have an abnormal number of chromosomes there. Instead of having 2, they have either 3 or 1. Translocations and deletions of chromosomes can also occur. So part of the chromosome moves and it doesn't move to where it's supposed to. So some important vocabulary I would expect them to ask you about is phenotype. This is the observed trait. So when I look at you, if I see red hair, that is your phenotype. If I see blue eyes, that is your phenotype. Your genotype is your genetic makeup. This says what color your hair will be based on the genes. So the difference is this says what color your hair will be. With the phenotype, that I can physically see what color your hair is. The gene is a region of DNA that describes a trait of an organism. For example, the eye color gene. And the allele is a different form of a gene. So there are different alleles. There are different versions, like brown eye color alleles, blue eye color alleles. These alleles represent certain traits. Humans have 2 alleles per trait, one inherited from each parent. The gene is the DNA that serves as the basic unit of heredity, and it appears throughout the length of each chromosome. Each chromosome has a unique set of genes. Heterogeneous are alleles that are different from one another. Sometimes one DNA allele will dominate the other, but these are 2 different alleles for the same trait. So, in other words, maybe I got one blue eye and one brown eye. Okay, one blue eye from mom, one brown eye from dad. In that case, whichever is the dominant one is what your eye color will typically end up being. Homogeneous is when we get 2 identical alleles that express the same trait. So if they're homo or homogeneous, then I would have 2 blue eyes, one from mom, one from dad. Again, the karyotype is a systematic arrangement of the chromosomes, and that helps us look for chromosome errors. Non-disjunction is when the chromosomes don't separate the way they're supposed to during cell division. And then both chromosomes end up going to one daughter cell and none go to the other daughter cell. This causes errors in chromosome numbers like trisomy 21 or Down syndrome. So really you should have 20 there, but you have 21. With monosomy X. So mono means 1, okay? So you have 1 there instead of 2. And this can cause spontaneous abortions, or it can cause the changes that we see in Down syndrome. Translocation, this is where the segment of the chromosome is moved from one part of the chromosome to another, or it's moved to another chromosome. So it's only a segment of the chromosome. A mutation is a permanent change. When the gene mutates, it can produce a trait different from the original trait. So sometimes people will develop something like sickle cell disease or something, and no one before them had the disease that we're aware of. This can be from a spontaneous mutation. So it produces a trait that's different from the original trait, and this can be transmitted during reproduction. Some mutations can cause serious disorders. that occur in 3 different forms. So mutations can be single gene disorders, chromosome disorders, or multifactorial disorders. In autosomal disorders, this happens when there's either too many or not enough chromosomes, and they affect the shape of the chromosome and cause a defect in it. Or it could be some other large or small mutation. 2 examples of autosomal disorders are trisomy 21 and cry-du-cat. Trisomy 21 is when there's an extra chromosome 21. This is called trisomy 21 or Down syndrome. Trisomy 21 means there's 3 copies of the chromosome 21, and Down syndrome occurs when there's a non-disjunction, that is, the chromosomes do not separate properly during the process of meiosis. For congenital defects, sometimes just a single gene is affected. Sometimes they're multifactorial. They could be inherited or caused by tetragenic agents. So like taking some sort of medication or, alcohol, anything that's harmful to the baby when it's in utero. And this could be anything like smoke, alcohol, illicit drugs, even some of your big farm drugs. In your book, it's going to talk about Punnett squares. These are used to predict chances for having a child with one of the following types of disorders: autosomal dominant, autosomal recessive, sex-linked dominant, or sex-linked recessive. So if someone were going to counseling, okay, for genetic counseling, and they were trying to determine and wanted to know if they were going to have a baby with a potential problem, and this is something people might do even before they get married, they might go for genetic counseling because they might not want to marry somebody else if it's going to produce a baby that's going to have problems. So we can use these Punnett squares to predict patterns of heredity. And that's probably the question it will ask you regarding this. A man who is heterogeneous for brown eyes marries a woman who's homogeneous recessive for blue eyes. What type of phenotypes or genotypes of their 4 children? So you would use this to try to calculate what would be the chances of what they would potentially produce. Okay. Dominant genes will dominate any situation, even if only one parent has the gene. If it's a recessive gene, both parents would have to carry the gene and pass it on for the child to inherit it. This diagram shows the possible offspring of a parent with recessive normal genes and a parent with altered dominant genes. With each pregnancy, there's a 50% chance that the offspring would be affected. All right, so the affected parent would pass the altered gene to half of the kids. That's all it's saying. All right. What you really have to remember here from these is that if it's dominant, the dominant gene is going to take preference here. If it's recessive, then you have to get 2 of those genes, one from mom and one from dad, for that allele or that phenotype to present itself, or that disease. So with autosomal dominant, you need 1 gene from either parent to receive the trait. If your father has 1 copy of a mutated gene from an autosomal dominant condition and your mom doesn't, there are 2 possibilities for you to inherit the disease. They each have a 50% chance. Okay. So for autosomal dominant, you have a 50% chance of either getting the affected gene or the disease from your dad and getting an unaffected gene from your mom. If that happens, you'll have the condition because it's autosomal dominant, and you only need 1 affected gene to get it. If you get the unaffected gene from your dad and the unaffected gene from your mom, you won't have the disease. You're also not going to be a carrier. because you don't have anything. You have two normal genes. In autosomal dominant, you only need one of your parents to pass it on, and you have a 50% chance of getting it. If one of your parents has two affected genes, then you have a 100% chance of being born with it. If you developed a new mutation of some sort, you could also get an autosomal disease, okay, because of the spontaneous mutation. Any questions on that?
Yes, it was like 2 or 3 slides ago when you were doing the bee. I was like a little confused with the bee and the bee, like all the bees in the box
So
on
you
how
don't
to.
need to know that, okay? Don't
Okay,
worry about the B's and the A's. Those are representing the dominant versus the non-dominant genes there, and normal versus abnormal. You don't have to know it that deep,
okay,
okay? What you have to know is that if it's autosomal dominant, that you only need one gene from one of your parents to get it. And
okay. Thank
you also have to know that you have a 50% chance of getting it, okay? Or not getting it, right? Because there's a 50% chance that your parent with the affected gene will give it to you. He could also give you a normal gene. If the other parent doesn't have it, then they're just going to give you a normal gene anyway. So with these, you have a 50% chance of getting the affected gene, a 50% chance of getting the unaffected gene. And if only one parent has the affected gene, then that means you have a 50% chance of getting the disease, a 50% chance of not getting it. And you wouldn't be a carrier here because there's no carrier condition here. Those are the three main things that you have to know about this. Everybody with me now?
Yep, got it.
Okay, what autosomal recessive, this is a variety of conditions. So this would be like cystic fibrosis, sickle cell, and PKU. Now, cystic fibrosis affects your exocrine glands, the lungs, and the pancreas because this is a problem with your CTFR, um, cystic fibrosis gene, and it causes your mucus to be real thick and sticky. And so it's going to plug up anything in the body where a duct is, mostly lungs and pancreas, but it could be any place where there's a duct and mucus has to go through because the mucus is going to get stuck. There's also a problem between the sodium and the chloride. And usually sodium and chloride work together because sodium is positive, uh, chloride is negative, and they like to hang together. They're pals. They follow each other. They do things together. But here, there's a problem between the two of them, making that mucus real thick and sticky. With sickle cell disease, you know that there's sickling of the cells, okay? This is caused by hemoglobin S. So in the body, you are born with hemoglobin F. If you're normal, everybody's normal, born with hemoglobin F, okay? If that hemoglobin F turns over into adult hemoglobin, it will transgress over into hemoglobin A. And that's normal hemoglobin. And you don't have sickle cell. If that hemoglobin F turns into hemoglobin S, then you have sickle cell, okay? You have that disease, sickle cell. Hemoglobin F is never usually affected. That is fetal hemoglobin. Okay. That is not affected by the sickling of the cell. But once it transitions over to the adult type of hemoglobin, then we will see a problem. So you'll either go to hemoglobin A and you don't have sickle cell, or you go to hemoglobin S and you do. You also could have sickle cell trait. Okay. Because with autosomal recessive disorders, you need two of those bad cells to get the disease. If you get one good cell from mom and one bad cell from dad, you would have the trait, but not the disease. So you would be a carrier, but you don't have the disease. With PKU, they're missing an enzyme there that helps break down ultimately the protein and the tyramine in the body. So in recessive disorders, both parents have to pass on the defective gene in order for the child to be affected or to have a homogeneous child. Now, you know that homogeneous means what?
The same.
Okay, so that means they got two of the same cell or gene and they were both defective. Okay, so that's what it means when it says they produced an effective, homogeneous child. They produced a child that got two of those defective genes because homogeneous means the same. Male and female children would be affected equally. If the child is heterogeneous, that means they got one normal gene and one diseased or one bad gene. In this case, they'll be a carrier. And typically, they don't show clinical signs of the disease. In some cases, people can, okay? Like in sickle cell, if they go into an area where they're under high stress and it's like, let's say they go to Colorado for something and they're there and they're under high stress while they're there. Because they're in an area where the oxygen levels are going to be affected, they're under stress, and other factors that contribute, they could have some of the clinical signs. They still don't have the disease, but they could present. So, your book is right on this to a point, but sometimes people with traits will show some of the signs of the disease. And I want you to understand that because you might have people in your family and they don't have sickle cell disease, but you might see sometimes that they struggle. And I don't want you thinking that that struggle is not real because it's real. All right. But they just don't have the disease. But sometimes under certain conditions, they can present with some of those traits. All right. So in each pregnancy where each parent is heterologous, that means each parent has one normal and one abnormal gene, then the child could be a carrier and show no signs of the disease for the recessive trait. The probability of inheritance is the following. Okay. So here, this is if each parent is heterogynous, meaning that they each have one affected gene, one unaffected gene. Okay. So if each parent has one affected, one unaffected gene, then there's a 25% chance the child is born with the unaffected genotype. So each parent might give them an unaffected gene. A 50% chance the child would be born with the carrier genotype. So 50% chance that each parent gives them an affected gene. And a 25% chance that the child would be born with the affected disease or genotype. I'm sorry, 50% chance that the child would be born with carrier means what? Let me go back to that. So if they're a carrier, how many genes did they get that are bad?
They got both from both parents.
One, just one.
Oh,
I said,
one.
yeah,
One.
just one. Remember, carriers only get one bad gene here. If they're born with the affected disease, they got two bad genes, one from each parent, or, if the parent had two bad genes, they could give two, but the parent would be homogenous if they had two bad genes, right? Heterogeneous means the parents only have one bad gene each. Anything I need to explain more there? Anybody confused? Need me to break it down again?
Yeah, can you say the heterologist and the other one again?
Okay. So homogenous means that they got two defective genes, one from each parent. Okay. If they're homogenous with the disease, they got one affected gene from each parent. Heterogeneous means they only got one bad gene from one parent and a normal gene from the other one. In that case, they're going to be a carrier. So
Okay,
any
thank you.
recessive order, okay, both of the parents would have to pass on a defective gene in order for the child to get the disease. Heterogeneous means that the child has one normal gene and one bad gene. In a recessive disorder, if they get one normal and one bad gene, then they'll be a carrier, but they don't have the disease. So it really goes back to what the parents have. What the parents have, what do they give to the child? And with X-link, mom gives the X chromosome to the offspring, dad gives the X chromosome to the daughter, but the Y to the son. The sons will carry the X from mom. For recessive traits, XX and YY are affected. The male inherits an X-linked altered gene. He'll express the condition because he only has one X chromosome. So all the genes on the X chromosome would be expressed. The Y chromosome carries no normal allele to compensate for the altered gene. Females inherit two X chromosomes, so they could be heterogeneous or homogeneous for any allele. I'm just going to pause this for 1 second. All right, so the alleles for the sex link are usually carried by those X chromosomes, and the Y chromosome doesn't carry the same genes as the X. Genes for X-linked disorders are recessive, but are usually manifested in males that are heterogeneous that lack the matching normal gene on the Y. Females are usually carriers and they don't have clinical signs when they're heterogeneous. Examples of X-linked recessive disorders are hemophilia A and Duchenne muscular dystrophy. So typically with these disorders, you're going to see them in the male, but not necessarily in the females. Females will typically be more carriers. Carrier females have a 50% chance of producing an affected male and an equal chance of producing a carrier female child with every pregnancy. The affected male will usually transmit the defect to all his daughters and they become carriers. The sons will not be affected or carriers if the male is the one passing it on. Okay, because the male only passes Y chromosomes to his son. Down syndrome is a trisomy. So here we have 3 chromosomes instead of 2. All right. So this person is going to have 47 chromosomes total. And it can lead to things like intellectual delays, shortened lifespan, oblique eyes, a small chin. So some of the things your book really talks about is that protruding tongue, those brush filled spots on the eyes, which are like white dots. Okay. The other one that your book mentions is Turner syndrome. Turner syndrome occurs when there's only one sex chromosome, the X chromosome. So this person only have 45 chromosomes, and this could cause physical abnormalities and a lack of ovaries. This is going to occur in women. And what you'll see is infertility here usually. So short stature, webbed neck. They can have other problems. I put a little picture here. Okay, now if you look at her, that's her phenotype. That's how you're going to see somebody with Turner syndrome present. And usually they'll have webbed feet, webbed neck. Klinefelter syndrome is another one that your book talks about. I don't have a slide up here for this, but I am going to add it. Okay. In Klinefelters, they have an extra chromosome. So instead of XY, they have XXY, or polysomy, it's called. They have 47 chromosomes. And usually these clients will have small testicles. Sperm is not produced. Again, they're going to have problems with fertility. Multifactorial disorders, these involve a lot of different genes combined with environmental factors. So some of your common examples of multifactoria are going to be things like that cleft palate, that congenital hip dislocation, congenital heart disease, diabetes, and encephaly. I did have a picture here. I think I didn't put it on here, but I'll add it for the anencephaly and for the hydrocephalus. Okay. And then some other things that we might see are developmental disorders. So these are usually due to exposure to some sort of environmental during pregnancy or before pregnancy, like radiation, which can cause changes in the sperm or the egg. Damaging effects to the fetus from alcohol, cigarette smoke, cocaine, radiation, pharmaceuticals. Damage from chemicals like mercury in food and water, or drugs that can cross that placental barrier. So, in pregnancy, they'll tell you not to eat things that are high in mercury, like tuna. A lot of seafood is high in mercury. You also have to worry about torch, and I would be aware of this, okay? Torch is toxoplasmosis. That usually comes from cat litter. Hepatitis
Are you
B.
showing a slide to match that? Because
I'm
we want to
not.
post. Okay.
I'm not. You're not going to get a slide for this because remember, I just said I have to add some more slides. I just said that literally. All right. So just listen to the video. When I update the slide in Google, it will update to match what I'm talking about. All right. So, torch, you want to be familiar with. This is toxoplasmosis, mumps, rubiola, varicella, gonorrhea, syphilis. These are all diseases that can cause the baby to die or cause other harmful damage to that fetus. Okay, that's pretty muchly it for chapter 21. And I will add those slides on. Okay, so by tomorrow, those slides will be on there. And tomorrow, we're going to go over some things that you guys covered earlier in this course. Like right after the midterm, we're going to go over some of those chapters so that we can familiarize you with those. All right, so I'm going to stop recording here, but I am going to go over these questions with you real quick. There's only a couple of them, and these are from last time we met.